Good afternoon and welcome. On behalf of the American Heart Association, I am excited to welcome you all today to the AL-Amyloidosis National Webinar. This webinar builds on the momentum of our National AL-Amyloidosis Patient to Provider Connection Forum held on March 12th. A special thank you to Alexion AstraZeneca Rare Disease for being a proud supporter of the AHA's National AL Amyloidosis Patient to Provider Connection Forum. My name is Deborah Marie Keating, and I serve as the Director of Operations at the American Heart Association, overseeing our work in amyloidosis. Along with the support of my colleague, Kayla Hadley, we're thrilled to welcome you all to today's webinar. Thank you again for joining us as we have great discussion ahead. Just a few housekeeping items. The webinar is being recorded. All participants are muted upon entry. The recordings will be made available as enduring resources in a few weeks on www.heart.org. And participation is encouraged today. We welcome open conversational discussion, so please engage and share your thoughts. To note, there is dedicated time at the end of today's webinar for Q&A. However, you may submit your questions via the chat at any time. During the live Q&A at the end of today's webinar, you may submit any questions into the chat, use the raise your hand feature, or request to be unmuted to ask your chat directly. Taking a look at today's agenda, we'll begin with a brief welcome remarks to set the stage, followed by key takeaways from the recent AL Amyloidosis Patient to Provider Connection Forum, including insights shared by expert clinicians and health system leaders. Next, we'll review findings from the surveys administered to forum attendees and highlight innovative strategies being used to address common challenges in diagnosis and care coordination. We're also excited to officially introduce the AL Amyloidosis Educational Toolkit, developed to support earlier recognition and strengthen multidisciplinary collaboration in patient care. We'll conclude today's session with a Q&A, so we encourage you to note any questions as we move through today's program. As we begin today, we want to take a moment to recognize and thank the speakers who contributed to our March forum. The insights and perspectives from this group advanced important discussion on multidisciplinary care and patient engagement. A special thank you to Linda Perez, our patient advocate, for sharing her personal journey. The patient voice brought critical dimension to the conversation and underscored the importance of this work. We are honored to be joined today by three nationally recognized leaders in cardiac amyloidosis care and research. Dr. Kevin Alexander is a nationally recognized expert in advanced heart failure, cardiac transplantation, and amyloidosis at Stanford Medicine. Dr. Melissa Lyle is a leading cardiologist at Mayo Clinic, Florida, specializing in advanced heart failure, cardiac transplantation, and cardiac amyloidosis. Dr. Matthew Moore is a global leader in geriatric cardiology and amyloidosis at Columbia University Irving Medical Center, serving as the director of the Cardiac Amyloidosis Program. With that, I am pleased to turn it over to Dr. Melissa Lyle, who will open today's webinar with an overview of AL amyloidosis and a summary of key insights from the recent forum, including what we learned from leading clinical experts. Dr. Lyle, over to you.
All right. Thank you so much, Devin. And good afternoon, everyone. Thank you so much for joining. And I will be doing an overview of everything that we learned from our forum back in March. So I first want to emphasize some of the key takeaways that we had from the forum. We really emphasized bridging the knowledge gap, increasing awareness of AL amyloidosis. We talked about early diagnosis really being critical. We discussed a multidisciplinary approach, and then we also discussed addressing how to address care disparities, and then we talked about strengthening patient advocacy. So I'm going to start off with a disease overview and really what we think about when we describe amyloid. So how do I describe amyloid to my patients? I typically describe it as an umbrella term. What it is a disorder of misfolded precursor proteins. Those proteins then aggregate into a beta pleated sheet configuration, forming insoluble amyloid fibrils that then deposit extracellularly into different organs and tissues. And there's over 35 different proteins in the body that can become misshapen and misfolded and go on to form amyloid fibrils, and we refer to those as being amyloidogenic. And the identification of that precursor protein is really crucial because it helps us to guide therapy. And when we think about the two most common types of amyloid that affect the heart, we think about AL amyloidosis and ATTR amyloidosis. The A stands for amyloid, the rest stands for that precursor protein. And I like to think about the protein, but then also the protein factory, the organ that produces the protein that causes a problem. So in AL amyloid, the protein is going to be the immunoglobulin light chains, and then the protein factory are those diseased plasma cells within the bone marrow. For TTR amyloid, the protein is going to be transthyretin or TTR, and that's a carrier protein that carries whole retinal binding protein and thyroxine, and the protein factory is largely the liver. When we think about AL amyloid, this is a systemic process. You can see here the plasma cells in the bone marrow that are producing the immunoglobulins that then dissociate into heavy and light chains. And it's those light chains that get overproduced and can become misshapen and misfolded and go on to form those amyloid fibrils. And those amyloid fibrils then can deposit into the myocardium and lead to a restrictive cardiomyopathy. There's over 3,000 cases of AL amyloid that are diagnosed each year, and about 75% of those have cardiac involvement. And so, again, they can have that restrictive cardiomyopathy component, but also the light chains can be directly toxic to the heart muscle as well. So here you see an example of a heart that's been affected by AL amyloid. And those amyloid fibrils, those green amyloid fibrils, weave themselves into the myocardium, creating that restrictive cardiomyopathy. You can also see here that depiction of how the light chains can be directly toxic as well, causing oxidative stress, necrotic injury, and apoptosis. So these are the three most common types of cardiac amyloidosis that we see: AL, and then TTR, whether that's wild type or variant or hereditary. And of course, we're going to focus on AL amyloidosis and how this can present. So, because again, it's a systemic process, it can have multi organ involvement. Often, patients are presenting with heart failure. Again, 75% can have cardiac involvement. Patients may present with hepatomegaly, nephrotic syndrome if significant renal involvement, peripheral and autonomic neuropathy, carpal tunnel, and macroglossia and periorbital purpura are often thought to be almost pathognomonic for AL amyloid. There's an estimated annual incidence of about 1 in 75,000 to 100,000, a prevalence of 1 in 25,000, and 1 in 7 patients with multiple myeloma have concomitant AL amyloid. And we've already discussed that 75% can also present with cardiac involvement. During our original forum, Dr. Kevin Alexander from Stanford talked about addressing care disparities for AL amyloidosis, and I want to just highlight a few things that he mentioned. So this is from one of Dr. Alexander's publications, and this study looked at both the temporal and regional trends for amyloidosis mortality rates. And this study emphasized a couple of points. The first is that men tended to have higher reported amyloidosis mortality related events, and that Black individuals had higher mortality by race. But if we look at the map, it's interesting to note that the Southeast, despite a higher proportion of Black individuals, actually had lower reported amyloidosis mortality rates. And this really speaks to maybe more of underdetection. And are we underdiagnosing amyloidosis in certain racial ethnic groups compared to other groups. And this is another study by Dr. Alexander and colleagues, and they looked at the Centers for Disease Control, the Wonder database. And this was really focused, a study that looked at how social determinants of health could affect amyloidosis detection rates. And if you look on the right, this is the social deprivation index score. And this social deprivation index score includes things like poverty level, access to transportation, other measures of health literacy. It essentially serves as a surrogate for social determinants of health. And if you look at the amyloidosis mortality heat map on the left, and if you think about overlaying these two maps, you can see that areas with a higher social deprivation index are going to be areas that are also lower in terms of amyloidosis detection. And then Dr. Alexander really emphasized that this limited disease awareness is something that we really need to focus on first and foremost. Increasing awareness leading to earlier detection is so important, particularly for AL amyloidosis, where delayed diagnosis can increase mortality. So, we've talked about how early diagnosis is key and critical. So, let's dive into how we actually make the diagnosis. So, the diagnostic approach for cardiac amyloid really comes in two phases. This includes the suspicious phase and then the definite diagnosis phase. So, let's start off with the suspicious phase. When should we be suspicious for cardiac amyloid? And the first would be if you're seeing increased left ventricular wall thickness. Often the cutoff that we use is 12 millimeters, but there have been some recent literature to suggest that maybe we should be indexing by body surface area or using a thinner cutoff for women, having a little bit of gender difference. But typically, we're thinking about left ventricular wall thickness greater than 12 millimeters, plus one or more clinical clues. So, what are those clinical clues? Well, we've talked about a few of them. So, heart failure, particularly heart failure with preserved ejection fraction in an older adult, autonomic dysfunction, neuropathy, particularly if there's not another clear cause for neuropathy, bilateral carpal tunnel syndrome. We've already discussed perioral, periorbital purpura, and macroglossia. We often hear about low voltage on the ECG. It is important to remember that only 50% of patients with AL amyloid meet true low voltage criteria. So we think more about the discrepancy that we would see between what we're seeing on the ECG and then what we see on other imaging modalities, the wall thickness that's seen on echo or MRI. And that decreased QRS voltage to mass ratio can be more indicative. Persistent elevation of cardiac biomarkers, intolerance of guideline-directed medical therapy, all of these things can be clinical clues to suggest possible cardiac amyloid. And this is really just a nice depiction of the systemic process of AL. You can see the periorbital purpura, the macroglossia, and then how also not only does the heart get affected, but the kidneys, the GI system, the nerves, truly a systemic process. Now, looking more again towards the imaging modalities and what we would expect to see on echo and MRI. Well, we know echo serves a major role in the non invasive assessment for cardiac amyloidosis, and we would expect to see increased biventricular wall thickness. We often see biatrial enlargement, thickened valve leaflets, and a thickened interatrial septum, and a pericardial effusion can be quite common as well. The diastolic assessment is very important for any infiltrative process, and we often are looking for that transmitral restrictive filling pattern with an E to A ratio that's greater than 1.5, a shortened deceleration time, a reduced A wave velocity, and this diminutive A wave can also be indicative of left atrial mechanical failure, maybe cluing us into those patients who may be at higher risk for intracardiac thrombus, even despite not having atrial fibrillation, since we do know that patients with cardiac amyloid are at very high risk for intracardiac thrombi. And then reduced tissue Doppler velocities, often less than 5 centimeters per second. The global longitudinal strain has really been proven to be an accurate and reproducible tool to help us differentiate cardiac amyloid from other types of increased left ventricular wall thickness. And what do we see with the strain pattern for amyloid? We often see that the base of the heart is more affected, so abnormal strain at the base and mid ventricle with relative apical preservation or sparing. And this is a classic bullseye appearance of someone with cardiac amyloid with that cherry on top appearance with the darker red at the center, indicating preservation at the apex. And can we use echo to give us a prognosis for amyloid? So we can. So from an echo standpoint, going back a slide, there we go. So, from an echo standpoint, this was a study that looked at over 700 patients with AL amyloidosis, and they tried to establish independent echo predictors of mortality. And this included a stroke volume index of less than 33, that was an independent predictor of mortality, as was strain with a cutoff of negative 14. Now, thinking about other imaging modalities, then we turn to cardiac MRI. And this can be utilized as an adjunct to echo and can be very helpful in terms of the non invasive assessment for cardiac amyloid. And we're looking at both a morphologic and functional assessment, again, looking for increased biventricular wall thickness. We look at native T1 signaling, extracellular volume, as well as the presence of late gadolinium enhancement. And this is an example that's classic for cardiac amyloid for late gadolinium enhancement in a subendocardial pattern. And the nulling pattern can often be seen and described with cardiac amyloidosis. So, this is a normal nulling pattern. And what do we mean by nulling? This is rendering the myocardium or rendering black. So, here you can see that the blood pool is nulled or rendered black prior, if we follow these slides, prior to the myocardium being rendered dark or black. And this is a normal nulling pattern indicative of a low extracellular volume and a low amount of gadolinium that's retained in the myocardium. But then, if we think of an abnormal nulling pattern, here we see that the myocardium is rendered black or nulled prior to the blood pool. And this is more indicative of increased extracellular volume and a large amount of gadolinium that's retained within the myocardium, consistent with later stages of cardiac amyloid. So once we have a suspicion for cardiac amyloid, what do we do next? So we have echo MRI findings that are suggestive, we have clinical clues. What would be the next step to move forward with the diagnosis? So I want you to think about, are there blood tests to screen for amyloid? Would you get a CBC with differential, a prealbumin level, serum-free light chains, or beta 2 microglobulin? So think for a second of what would be one of the first tests that you would get if you have a suspicion for amyloid. And we're going to talk about this further, but serum-free light chains would be part of that initial monoclonal protein screen that you would get to evaluate first for AL amyloid. So now let's move on from the suspicious phase to the definite diagnosis phase. And this is when we turn to our diagnostic algorithms. And with this diagnostic algorithm, again, that first step is going to be the clinical suspicion plus the echo and MRI findings. And once we have that clinical suspicion for amyloid, we have to rule out AL amyloid first because AL amyloidosis is a medical emergency and we want to make sure that we don't delay the diagnosis. And so the first step is going to be the monoclonal protein screen. And that monoclonal protein screen includes serum-free light chains, as well as serum and urine immunofixation. And it's important to recognize that SPEP and UPEP alone are not going to be sensitive enough. And so once we do this initial screen, if there is abnormalities on that monoclonal protein screen, we want to have an urgent referral to hematology because that would be a suspicion for AL amyloid. And our hematologists are often getting a fat pad biopsy, a bone marrow biopsy, And one important point is that for AL amyloid, tissue diagnosis and tissue confirmation is needed. So if there are no amyloid deposits that are detected on fat pad biopsy or bone marrow biopsy, then it would be important to then biopsy the most affected organ, which in our case is often going to be an endomyocardial biopsy. And of course, our talk is going to be focused on AL amyloid, but I do just want to mention that in the absence of a monoclonal protein, so a normal monoclonal protein screen, that's when you're able to utilize cardiac scintigraphy to evaluate for TTR amyloid. And if there is grade 2 to 3 uptake, that would be consistent with TTR amyloid, and you can get genetic testing to determine if it is wild type or hereditary or variant. And it is important to mention just a few points about cardiac scintigraphy that are key. So these are the radio tracers that are utilized. In the US, we use PYP, so you often hear about the nuclear PYP scan. And the reason why I want to mention this is that the nuclear PYP scan has been a way to non-invasively diagnose TTR amyloid. And this was the seminal paper that looked at over 1,200 patients with a suspicion for amyloid. And 850 plus of those patients actually had a histologic confirmation of amyloid. And so, with this study, in the absence of a monoclonal protein, grade 2 to 3 uptake, what had a positive predictive value and a specificity approaching almost 100% for TTR amyloid. But the key points, and it's so important to remember, is that 20% of biopsy proven AL patients had grade 2 to 3 uptake. And so a monoclonal gammopathy must be excluded in order to utilize this cardiac scintigraphy. And when we think about the cardiac scintigraphy or nuclear PYP and how we can get some false positives, AL amyloidosis, you see here, one of the causes for a false positive scan. So, when we think about our diagnostic algorithm, again, if your suspicion is for cardiac amyloid, make sure to rule out AL amyloid first. Move forward with that monoclonal protein screen. Make sure that includes serum free light chains and serum and urine immunofixation. If an abnormal monoclonal protein screen, urgent referral to hematology for further evaluation. And I want to emphasize one point just again to drive that home about the cardiac scintigraphy. You may be seeing a patient who has testing done simultaneously if they were from out of town. So they may have a monoclonal protein screen, but then also a cardiac scintigraphy or a nuclear PYP scan done. And say both were positive. So monoclonal protein was present, and then a nuclear PYP scan was positive. This is when you need to move forward with that endomyocardial biopsy. And I really love this acronym, courtesy of Dr. Dan Judge, that was shared by Dr. Martha Grogan, that if there is an MGUS, then you must go under the skin. And what do we expect to see on biopsy? So these are just two examples of an H&E stain with amyloid deposits and then a sulfated Alcian blue indicating amyloid deposits. Sulfated Alcian blue is going to be a little bit more sensitive but less specific than Congo red. But typically what we're looking for is amyloid deposits by Congo red staining, and then we can utilize mass spectrometry most commonly to diagnose the amyloid type or immunohistochemistry. And once we have made a diagnosis of amyloid, then how do we treat AL amyloidosis? So during our original forum, we had a fantastic lecture by Dr. Heather Landau from Memorial Sloan Kettering, hematologist, who gave a fantastic overview. As a cardiologist, I cannot do justice to her wonderful talk, but I wanted to give some of the highlights. So she emphasized that the goal of treatment for AL amyloid is really to target the diseased plasma cells. So once we're able to eliminate those plasma cells, then we can reduce the circulating free light chains, which are really the pathologic entity, and then that can lead to organ response. And it's important to recognize that with deeper hematologic response, that gives you the opportunity for improved organ response and improved survival. Dr. Lindahl also talked about the first immunotherapy for AL amyloidosis, daratumumab, and she referenced the landmark trial Andromeda that looked at patients being started on sort of standard of care therapy with CyberD, cyclophosphamide, bortezomib, and dexamethasone, and they were randomized to with or without daratumumab added to that. And after 11 months, the daratumumab group saw a tripling of hematologic response from 18% to 52% and a doubling of organ response. So much so that the CyberD Dara combination is now FDA approved drug regimen for AL amyloidosis and our standard of care. And Dr. Landau also in her excellent talk gave us an overview about the questionable role of stem cell transplant now in the era of DARA and CyberD. And then also talked about the role of venetoclax in translocation 1114, and then also the clinical trials that are ongoing for anti-amyloid and amyloid-directed therapies. And then in our forum, we really emphasized a multidisciplinary approach. And with this, we had wonderful lectures by Dr. Eugene Brailovsky, Dr. Julie Rosenthal, and Dr. Brett Sperry. And with this multidisciplinary approach, we talked about growing an amyloid center of excellence. And as part of their lectures, they first referenced Dr. Brailovsky's publication on building an amyloidosis center of excellence. And this emphasis on partnering with amyloidosis centers, really emphasizing the amyloidosis center as almost a spoke and hub type model. And then they talked about identifying key stakeholders for the multidisciplinary approach, how to get institutional buy in when you are building an amyloidosis center, and then how to grow an amyloidosis center of excellence. And when we think about our key stakeholders, it's important to emphasize that your team will vary by institution. And so with AL amyloidosis, we have, of course, cardiology and hematology involvement. And given that it's a systemic process, also involvement from our GI colleagues, our nephrology colleagues. And so it's going to vary per institution, but that multidisciplinary approach is so key to creating an amyloidosis center of excellence. And everything that we've talked about is really focused on bridging this knowledge gap and increasing awareness. And even though our initial forum and also our webinar today is going to be focused on bridging the knowledge gap and increasing awareness, we did take time to identify some of the challenges that we face with AL amyloidosis. So, just to mention a few of these challenges. So, we have a delayed diagnosis. We can also see that with this, it's often a complex diagnosis. And then with the multi-organ involvement in complex therapies, that can be an added challenge. So during our initial forum, we wanted to address all of these challenges. And for the delayed diagnosis, we talked about education being the key to increase awareness, but then also screening tools. And Dr. Alexander really emphasized utilizing and leveraging technology. So we discussed utilizing artificial intelligence to help as a screening tool. And this is an AI ECG tool that we are lucky enough at Mayo to have embedded within our electronic health record. And you can see here just an example of a patient who had many ECGs and had normal ECGs for years. And then you can see this abrupt change in 2020. And although the patient was later diagnosed with amyloidosis, if someone had looked at that AI ECG tool earlier, then a probable diagnosis may have been made even prior to that initial clinical presentation. And so my colleagues in Rochester have done a lot of work in terms of this AI ECG tool. And Dr. Martha Grogan and colleagues published on this, and they highlighted a couple of key points. They looked at over 2,500 patients with amyloid, and they found that this AI ECG model had a positive predictive value of about 0.86 for predicting amyloidosis. And the violin plots show that two-thirds of patients with AL and TTR amyloid actually had a diagnosis made about 6 months prior from the AI ECG tool compared to clinical presentation. So this really emphasizes earlier diagnosis, and the earlier that we can diagnose someone, the earlier that we can initiate that life-saving therapy. So the benefits of screening increases awareness and recognition. And with implementation of screening, we have improved diagnostic accuracy. And with earlier diagnosis, this leads to earlier initiation of therapy and a potential change in the clinical course, because again, we know that these diagnostic delays can lead to increased mortality. And then we go back to thinking about all of the challenges. So, delayed diagnosis, but then complex diagnosis, how can we address this? And this is by those diagnostic algorithms that we have discussed. And then with multi organ involvement and complex therapies, the best way to address this is going to be with the multidisciplinary approach. And so with that, we emphasized all of the challenges in different ways that we can address the challenges that we see. So delayed diagnosis, education, and leveraging technology for screening tools, complex diagnosis, following our diagnostic algorithms, and then complex therapies and multi-organ involvement, always focused on the multidisciplinary approach. And with that, hopefully you were able to see a nice overview. And I want to end with just emphasizing the importance of patient advocacy. And so during our original forum, as Devin mentioned, we had Linda Perez who shared her story as an AL patient. And then we had wonderful updates from Mackenzie's Mission, the Amyloidosis Speakers Bureau, the Amyloidosis Support Group, and Amyloidosis Research Consortium, all to highlight the importance of strengthening patient advocacy. And so with that, just to emphasize the final takeaways from the forum, I want to make sure that everyone recognizes the importance of early suspicion for amyloid. So make sure to suspect amyloid with increased left ventricular wall thickness, plus those clinical clues. And know your diagnostic algorithm for cardiac amyloid. Rule out AL amyloid first because AL is a medical emergency. And make sure to avoid those diagnostic pitfalls, such as interpreting cardiac scintigraphy in the setting of an abnormal monoclonal light chain testing. And thank you so much for your attention.
Thank you so much, Dr. Lyle. As always, we're very appreciative for you. Next, I am pleased to welcome Dr. Kevin Alexander back to share key insights from our survey efforts. Ahead of the March Forum, survey efforts focused on understanding provider awareness, diagnostic barriers, and patient referral challenges related to AL amyloidosis. Following the forum, we assessed the impact of education and model sharing and gathered input to help strengthen current care practices and future strategies. The goal wasn't just to educate, but to spark system-wide improvements in AL diagnosis and care. And with that, we welcome Dr. Alexander.
Great, thanks, Devin. So in the next set of slides, I'm going to talk about the what we've learned from the forum. I think Dr. Lyle showed the depth and breadth of things that were discussed in the forum, and I think that it's been a powerful intervention in terms of improving awareness and our understanding of the disease, and also directions to go in the future to improve care for AL amyloidosis patients. So in order to get a sense of that, the magnitude of the intervention, we measured by surveys pre and post the forum. The forum surveys that were obtained prior to the forum that were obtained prior, we're really trying to get a baseline of who is attending the forum, as well as understanding of amyloidosis and perceptions of some of the barriers that exist for the disease. So I'm going to go over some of the baseline metrics. So this is who attended the forum. So shown here is 181 participants by specialty. Just apologies here. And the majority of people were in the cardiology specialty. So more than half of the participants were cardiologists, but there's good representation among, yeah, sorry, here we go, among other subspecialties. So hematology, neurology, as well as pharmacists and patient advocacy groups. There's smaller representation among some of the other medicine subspecialties, such as gastroenterology and pulmonary critical care. If we look at the credentials, so there's a broad representation across allied health professions. As you can see here, 40% registered nurses, but we also have social workers, pharmacists, MDs, as well as advanced practice providers. And I think this is great that we have not only a multidisciplinary representation by specialty, but also different stakeholders in terms of clinical practice, because this is going to be really important for improving management of this complex disease. In terms of healthcare setting, about half of the participants were affiliated with academic medical centers, but we also see good representation from community hospitals, as well as specialty clinics and patient advocacy groups. In terms of respondents who practice at amyloidosis centers, you can see a little under half are members of an amyloid center, but 60% are not affiliated with an amyloidosis center. And I think it's good to get both perspectives in terms of how to manage this disease, because many of these patients are going to initially present to a non-amyloid center. And so understanding how to raise awareness in these groups and improve referral pathways to amyloidosis centers will be really important. And you can see on the right that most people are not involved with direct amyloidosis research. And I think this is an area that we could discuss further, of ways to improve that and to collaborate across institutions to pool data together for this rare disease. So in terms of disease management, here I'll present the survey results for this. So for the pre-survey, participants were asked about decision making in AL amyloidosis and who are the key stakeholders for that. You can see here that about half believe that 40% believe that the clinician is the primary stakeholder for treatment. And what I like to see here is about 60% of people acknowledge this as a shared decision making between clinician and patient. I think with the complexity of treatment, the options that exist for diagnosis, this is really important to make sure that the patient voice is well heard. When we look at how well patients are informed about their disease prior to counseling by clinician, you can see many feel that they are minimally or not at all informed. And so this is where I think patient-facing educational resources can make a big impact. In terms of the barriers that exist for the evaluation and management of AL amyloid patients, you can see most of the problems are upstream. So a lack of awareness and delay in diagnosis is really where the bottleneck is for improving outcomes for AL amyloidosis. And downstream of that, things like delayed referral to amyloidosis or multidisciplinary centers are important, but not as prominent of barriers as you can see here. And about three out of four providers cited low disease awareness as the top barrier. In terms of referral for suspected AL amyloidosis,
Dr. Alexander, I can help advance slides if that's easier for you.
yeah, that'd be helpful. Yeah.
Yeah,
So that slide
absolutely.
is
I'll
6
take
seconds
it.
away.
Yeah, absolutely.
Okay. Yeah. So you can see for referrals that about a third of providers refer patients every time, and about a third rarely or never refer patients. In the post survey, you can see that after the education provided by Dr. Lyle and others, that people are more likely to refer patients, and those that haven't referred patients that are more likely to consider that in the future. And so I think that the forum helped to foster that collaborative or emphasize the importance of collaboration when managing these patients. Next slide. In terms of standardization of diagnostic workup, we saw some data from Dr. Lyle about automation for diagnosing AL amyloidosis, but that hasn't penetrated a lot of practices yet. You can see here that many places don't have a standardized protocol for AL amyloidosis. And so I think that there's opportunities to implement these at the institutional levels, but also at the national level. And we'll hear more about some of that from Dr. Maurer in the subsequent talk. Some of the things that have been included in these protocols are automatic referrals to cardiology and hematology, diagnostic pathway, specific diagnostic algorithms for AL amyloidosis, and ensuring that patients with AL amyloidosis have appropriate follow-up. Next slide. Since the forum, about 44% of respondents say that they've either implemented or planning to implement new diagnostic and referral pathways for AL amyloidosis. So I think that's terrific. And that's going to be an important step in addressing that bottleneck from diagnosis to treatment. Next slide. So some of those specific changes that participants were considering is improved coordination among cardiology, nephrology, and neurology, starting to educate patients and their families about the disease earlier, and also using diagnostic tests earlier in the screening algorithms. And I think that those are all going to be complementary in terms of improving timely diagnosis and treatment. Next slide. So some of the takeaways for actions that participants can implement with their teams to improve outcomes for AL amyloidosis. So enhancing coordination of treatment decisions, which oftentimes for this multi-organ systemic disease, balancing treatment efficacy and side effects can become a challenging scenario. And it's important to really bring all the clinical stakeholders together to make quick and decisive decisions. Making sure that patients get the appropriate workup, so things that aren't missing. So we've heard from Dr. Lyle the importance of serum-free light chains and serum and urine immunofixation. So making sure all the components of the diagnostic workup are completed in a timely manner. And also strengthening the referral networks for patients that are seen outside of amyloidosis centers. Next slide. In terms of confidence and the impact of education on patients, here are some of the survey results. So you can see that more than half the respondents had low or very low confidence in terms of diagnosing AL amyloidosis. And so I'll show you some of the post-survey data that shows the improvements that have been made in terms of awareness of this disease among the participants. Next slide. So as you can see here, most of the respondents stated that they had some increase in their confidence in diagnosing AL amyloidosis, with almost half having an increase a lot or moderately in terms of their confidence. They've also had an increase in confidence of interpreting the diagnostic test, which will be really key for triaging referrals to amyloidosis centers of excellence. Next slide. I think this question shows how much the education has improved among the participants after the forum. So these are clinical signs and symptoms that should raise suspicion for AL amyloidosis. And as you can see here, the percentage of respondents that identified these as red flags increased significantly across things like carpal tunnel syndrome, low QRS to voltage to mass ratio, as well as peripheral neuropathy. Next slide. Also, I think this is a great result as well, really highlighting that the vast majority of respondents understand now after the forum that serum-free light chains and serum and urine immunofixation are crucial for initially identifying those at risk for AL amyloidosis. Next slide. I think the forum also emphasized the fact that this is a medical emergency and suspected AL amyloidosis patients should be evaluated quickly. As you can see on the question on the left, that an increasing number of respondents stated that the initial diagnostic testing should occur within 1 to 2 weeks. I think that's terrific. It also is clear that participants have an increasing recognition that a biopsy is needed to confirm the diagnosis of AL amyloidosis. So there can be non-invasive testing that's suggestive of AL amyloid, but ultimately tissue is needed to confirm the diagnosis. Next slide. Next slide. So this is feedback from the respondents for the survey about some strategies that might be helpful in improving the adoption of best practices for AL amyloidosis. So kind of top line would be standardizing the clinical protocols for diagnosis and treatment, implementing multidisciplinary team meetings to share updates and to align clinical care strategies. And as we develop new diagnostic and screening tools, implementing those into our electronic medical records, and then ongoing training of medical staff as well as community practices is going to be important for improving the referral pipeline for AL amyloidosis. Next slide. So some of the resources that can help us in terms of improving awareness and education. So improving access to updated clinical guidelines and protocols, improving training, providing training and workshop for staff, and really emphasizing the importance at the hospital leadership and administrative level for providing resources to allow us to expedite care for these patients are going to be extremely important. In terms of some of the access to this medical information, we'll hear from Dr. Marr about results that have come out of the forum. Next slide. So to summarize, these were some of the key takeaways from the forum and what we gleaned from the participant surveys. There's metrics that show that there's an increased disease awareness among participants, as well as knowledge among providers. Clinicians are more confident understanding the red flags for AL amyloidosis and the need for timely diagnosis. And there's also increasing acknowledgement that institutional protocols and standardization of screening tools and diagnosis are going to be key in order to improve outcomes for AL amyloidosis. There's still a number of critical gaps that remain for this disease, but I think this is a great start for continuing the discussion about how to manage AL amyloid patients. Great, thank you.
Thank you so much, Dr. Alexander. We are excited to turn things over to Dr. Matthew Moore for the next portion of today's program, launch of our AL amyloidosis education toolkit. Dr. Moore, I'm happy to advance slides for you, or I did give you slide control, so whichever works best for you.
Probably would be best if you just advanced. That'd be great.
Yeah.
But I just wanted to take a moment to thank all my colleagues who've participated in this and really graciously thank the AHA for galvanizing not only a national group of experts, but patients, advocacy groups. This is clearly a major unmet need, and I'm very glad to see that there's movement in this particular regard. So as an outgrowth of the forum, we've created a new suite of tools through this initiative that I hope empowers clinicians and care teams to facilitate what we've been talking about, which is really early identification and management of patients with AL amyloidosis. As we've, I think, talked about, AL is a rapidly progressive disorder and, God forbid, can be fatal when not diagnosed early. And so we are really focusing our efforts in this particular regard. Unfortunately, delays in diagnosis remain common, and we believe that education is the single most powerful lever we have really to alter or change that. And so hopefully these tools will be useful in that regard. Maybe we can go on to the next slide. So actually one further up, if you don't mind, I think, before this, nope. So what you're going to see in a moment is a preview of our provider-facing AL amyloid educational resource page that's on the heart.org website. It was specifically designed for healthcare professionals to easily access all the tools that I'll show you to support, again, early recognition, multidisciplinary collaboration, and improved patient care. And from this site, the providers can download a clinician pocket guide, quick reference, and patient advocacy resources to really help connect people with, I think, very trusted support for patients. There are a lot of advocacy groups in this domain who help quite a bit. You'll find the links to the recordings from both the March forum on this webpage as well as today's session, and those will be available in the coming weeks. So the hope is everything's really centralized so that clinicians can access across specialties, being informed and equipped to make a difference in the patient's AL amyloid journey, if you will. Maybe next slide, if you could. So here we're, I think, featuring the quick reference guide, and it builds on the content from the pocket guide that we talked about, offers a more in-depth overview of AL amyloid care, includes a disease overview, key initial clinical clues to guide the diagnostic workup and common differential diagnoses, and also outlines, as we mentioned, referral strategies, highlights trusted advocacy partners and resources, and features a diagnostic algorithm really that highlights, importantly, the workup that we've talked about for AL amyloid to ensure a timely and accurate diagnosis. And this is really designed to be a practical go-to resource intended for use across specialties, so be it cardiology, hematology, internal medicine, and anything even beyond. Maybe next slide, if you could. Here's the clinician's pocket guide. This is an easy to use tool meant to support providers really at the point of care. And it highlights key clinical clues that should raise suspicion, so-called red flags for AL amyloid, especially in patients presenting with seemingly kind of unrelated clinical symptoms. It's a clue to amyloid at times. And again, includes suggested diagnostic next steps, help guiding providers toward, again, timely referral and further evaluation. Next slide, if you could. So the hope here is that we're going to, promote early suspicion. These flags that commonly lead to misleading presentations or non-specific ones, HFpEF, nephrotic syndrome, and nephropathy that all could indicate amyloid but don't get to the root diagnosis. And recommends, I think, that clinicians always think amyloid in your differential diagnosis and during, importantly, your initial assessment. We want to streamline the diagnostic approach, providing a step-by-step testing algorithm, including labs, imaging, and the need for biopsies, and try to reduce unnecessary testing that could delay the diagnosis or lead to missteps. Obviously, we want to support a multidisciplinary collaboration. We've used standardized language and pathways for use that is across specialties, agnostic to a particular specialty, and is ideal for, if you will, team huddles, tumor boards, or referral planning. Obviously, our goal is to improve patient communication and advocacy. And so we've, again, provided validated resources to share with patients who can be overwhelmed by this particular diagnosis and connects patients and families to national support networks. And obviously, we want patients to be, or the field to be accessible and actionable. We want it to be available, and it is in both print and digital formats at heart.org. And it's designed for use in multiple settings, academic and community settings as well. Maybe next slide. So I would just urge everyone to think about how to utilize these and encourage all the attendees on this call and anyone you interface with to download, print, bookmark these tools, share them with colleagues, particularly in high volume areas like primary care and general cardiology where patients are being seen. Emphasize their impact if you could. Remind people that in a life of a patient with AL amyloid, literally every single day matters. Education can change outcomes, and I really believe these tools can save time, guide next steps, get your patient the help they need faster, and really honestly save a life. So I would ask that maybe you take a few minutes after today's webinar and download the materials, review them, and share them with your team. Maybe bring it out to your next multidisciplinary meeting at your site. Or if you don't have a multidisciplinary team, think about starting one. These resources are really designed to support everyone in that regard. And I think finally, really share the advocacy materials with your patients, connecting them with a community that can make all the difference in supporting them through a very difficult journey. I believe together we can really improve diagnostic timelines, connect patients to the care they need, and ultimately reduce mortality from this really terrible condition. So I'll turn it back over to my colleagues at the AHA who may be able to demonstrate the website a little bit.
Thank you, Dr. Moore. I couldn't have said it as Dr. Moore mentioned and walked us through all of this material from today's event, the PDFs of the quick reference guide and the pocket card, the recordings from today's webinar, March's forum, and the handouts are all available on www.heart.org/AL-amyloidosis. We are so appreciative to our three clinical leaders, Dr. Moore, Alexander, and Lyle, for helping in the development of this material, and we're happy to share it all with you today. With that, I know we are a little short on time, but have one question that came through the chat that I think would be good to share just in the last couple minutes that we have here. If anyone else has a question, please feel free to pop it in the chat or raise your hand. But the first question is, what is the minimum abnormal AL testing that you have seen come back as AL amyloid? A lot of patients seem to have borderline labs from their CKD or potential MGUS.
Yeah, I think that's a really good question. And we didn't highlight the specific cutoffs for the serum-free light chain ratio. So just to kind of touch on that, the typical ratio that we would think about with someone with normal renal function would be 0.26 to 1.65, being that normal ratio, normal serum-free light chain ratio. However, we will see increased free light chains that are sort of increasing related to the reduction in GFR. So our patients with chronic kidney disease can have a higher ratio, and typically we can see cutoffs even as high as 3 for that kappa lambda ratio as their kappa light chains increase. So I would say that, in my experience, if I see a ratio that would be outside of that realm of normal for someone with chronic kidney disease, or if I'm seeing a monoclonal protein on their serum or urine immunofixation, then that's always going to be a referral to hematology for me so that I can make sure that I am not missing a diagnosis. I don't know if Matt or Kevin have anything to add to that as well.
Yeah, completely agree. And I think it highlights the challenges with this disease, that sometimes the lab abnormalities can be subtle or confounded by other conditions. And so I think you have to have a high level of suspicion. And if you're in doubt, refer to the experts, because sometimes there are these kind of unusual cases.
Wonderful. And I think knowing that we are at almost the top of the hour, I just want to again thank everyone for their contributions to today's event, to March's event. I know I see some people who led sessions in March in our participants here today. So thank you for joining us as well. As Dr. Moore mentioned, all of the recordings and toolkit materials are enduring resources on our website. If you should need anything, please reach out to our team. And we are so appreciative to have everyone join us today, and we hope that this really helps and is meaningful to your care for your patients.